Welcome to ADEF Journal Club. Today, we will have second part of Thyroid Year in Review 2025.
Hello, everyone, and welcome. Today, we're going to dive into some of the most clinically relevant findings in thyroid etiology from the past year. Think of this as a quick digest, all pulled from the fantastic Thyroid Year in Review article in Endocrine Practice. So, let's get right into it. You know, we've all been there. A patient comes in complaining of fatigue, we run the usual tests, but things still feel murky. Could there be something else at play, something subtler? Well, today we're going to look at some new evidence that really helps us unpack the complex dance between lifestyle, specific patient groups, and thyroid function. And our guide for this journey is this excellent review from Dr. Malini Gupta and her colleagues. They've really done the heavy lifting for us, sifting through the year's research to find the papers that are going to have a real impact on how we manage our patients every day. So here's the plan. We'll hit three main topics. First, the really surprising gender-specific ways that sleep restriction affects the thyroid. Then, we'll look at a new link between hemoglobin and thyroid function during pregnancy. And finally, we'll tackle the tricky relationship between TSH and cognition in older adults. And of course, we'll wrap it all up with three key clinical takeaways. Okay, first up, sleep. Now, we all know that not getting enough sleep can throw a wrench in the works system-wide. But what's really fascinating is some new research showing a very specific impact on the thyrotrophic axis, and it seems to play out very differently between men and women. So this pivotal study from Petrov and his team took a group of healthy adults and did something pretty interesting. It was a randomized crossover study where everyone did 6 weeks of getting enough sleep and then 6 weeks of mild sleep restriction. And we're not talking about pulling all-nighters here, just an hour and a half less sleep per night. Then, they checked to see what happened to their thyroid labs. And at first glance, the overall results weren't that dramatic. But here's where it gets really interesting. When these stratified the data by gender, a totally different story emerged. In premenopausal women, that mild sleep restriction caused a statistically significant drop in TSH. But in the men, nothing. No significant changes in their TSH or free T4 at all. So, what does this mean for our patients? Well, the researchers suggest that this sustained blunting of the TSH response could be a piece of the puzzle. It might help explain why we see women facing a greater cardiometabolic risk from sleep deprivation compared to men. It's definitely something to keep in mind when a premenopausal woman presents with metabolic changes that we can't quite explain. All right, now let's pivot to another critical population, our pregnant patients. For a long time, when we've thought about iron status and thyroid function in pregnancy, our focus has been on ferritin. But a huge new analysis is suggesting we might have been looking at the wrong thing. This was a massive meta-analysis from Part2 and colleagues. They pulled data from over 53,000 women to try and get a definitive answer to the question, what's the real relationship between a mother's iron status and her thyroid hormones during pregnancy? And the results were pretty striking. Just look at this table. When they defined iron deficiency by low ferritin, no significant difference in thyroid markers. But, and this is the key part, when they defined it by low hemoglobin, meaning anemia, the picture changed completely. Women with a hemoglobin under 11 had a significantly higher TSH, we're talking 2.31 versus 1.75, and a lower free T4. So the takeaway here is crystal clear. It seems like it's the hemoglobin itself, which is reflected by the hemoglobin level, that's really driving this connection, not just low iron stores sitting in the background. This really suggests that for our pregnant patients, hemoglobin is the more clinically relevant marker to be watching when we think about thyroid dysfunction. Okay, for our last topic, let's talk about our aging patients. This is a question that comes up all the time in the clinic. What is the link between thyroid function and cognitive decline? Well, the evidence here really calls for us to be cautious and thoughtful. A narrative review from Sinha and colleagues did a huge service by pulling together 2 decades of research, everything from RCTs to big observational studies, to give us a clear picture of where things stand on this really complex topic. And, the conclusions are full of nuance. They found no clear evidence that small TSH changes within the normal range have any impact on cognition. And this is really important. Treating subclinical hypothyroidism has not been shown to help cognition or prevent dementia. Now, while overt disease can cause cognitive symptoms, a direct causal link to dementia just hasn't been proven. The one thing that is clear, prolonged overt thyrotoxicosis does seem to increase the risk of dementia. And that leads us to probably the single most important clinical takeaway from all this literature. We have to be so careful to avoid iatrogenic or doctor-caused hyperthyroidism. Overtreating our older patients, maybe being too aggressive with TSH suppression for a low-risk thyroid cancer, carries a real cognitive risk without any proven benefit. So, we've talked about sleep, pregnancy, and aging. After going through all these new findings, what are the big, practice-changing points we can take back to the clinic? Let's break it down. Let's put this into action. First, for your premenopausal female patients with metabolic issues, ask about their sleep. It could be affecting their TSH. Second, during pregnancy, pay close attention to hemoglobin, not just ferritin, as a key indicator of thyroid function. And third, with your older patients, be cautious. Avoid unnecessary TSH suppression to help protect their cognitive health. What all these studies really point to is a bigger trend in endocrinology. We're moving away from one-size-fits-all medicine. The data on gender, pregnancy, and age are all pushing us toward a much more personalized approach. So the big question for all of us is, how are we going to integrate these kinds of nuances into our daily practice and into the next generation of guidelines? Thank you so much for joining me for this explainer.